Vasopressin, VA, antidiuretic. Okay. Vaso ADH. Yeah. So happy with it. That is the correct answer. So vasopressin is the correct answer. The rest, I think you all are on the right track. I feel like you all have the preparation that you need. These were just a few MCQs to just let you know that this is what they expect you to have. Now let's just go through the file and do the rapid revision. This file has basically the past MCQs in one-liners. Okay, that's all this is. Are you able to see my screen? Is my screen visible? Okay, brilliant. Right, let's go through this. So first, this is a rapid review, so it's going to be a bit random. Don't worry about it. This is just revision of what you've covered, but all of these points that are mentioned in this file have been tested. So keep this in mind. Cardiac action potential and antiarrhythmic drugs. So we remember we did this yesterday, so this should be fresh. Phase 0, phase 1, 2, 3, and 4. So phase 0, you've got impulses that reach from the SA node and spread throughout your myocyte. This is a bit of physiology that they can test as well. All your class A drugs are sodium channel blockers, and they will act on phase 0. So procainamide, lidocaine, flecainide. They have class 1 ABC, if you remember, and these will block your fast sodium channels, okay, and delay phase 0. Phase 1, initial repolarization. These are your fast sodium channels close and potassium channels open. Then you've got your phase 2 plateau phase. These are your L-type calcium channels where verapamil, diltiazem, and nifedipine, your class 4 drugs, act. Then you've got phase 3. This is where your calcium channel close, but potassium are still open. This is where class C, amiodarone, and sotalol act. So they inhibit this phase by blocking the potassium channels. And then you've got phase 4, which is the resting membrane potential. And the cell returns to its resting state until next impulse, where the beta blockers are acting. Okay. This is your diuretic classification. Again, many MCQs can come from this one. If you want to, I will share the file, so you will have it. You don't need to take any photos of this one. We're just going to quickly go through this, and I hope that we can just do a quick session so that I don't take a lot of your time. Furosemide, torsemide, bumetanide, ethoxynic acid. And like I said, loop diuretic acts on the loop, but they can ask you thick or thin in the options. So keep in mind it's thick ascending loop. And they inhibit sodium potassium 2 chloride transporter. Okay. Thiazide acts on your distal condylated tubules, and they inhibit your sodium chloride transporter. Potassium sparing ones we've already done. You have to remember that they act on your aldosterone receptors in your late distal convoluted tubule and collecting duct. From where can we get this file? It's going to be uploaded into your Google Classrooms. Then you've got osmotic diuretics, which have an osmotic effect. Then you've got carbonic anhydrase inhibitors, acetazolamide, which will inhibit your sodium hydrogen exchange at the proximal convoluted tubules. Okay, many MCQs will come from this, and then you've got your side effects. So for loop diuretic side effects, you've got GoPanda. If you can remember the mnemonic, go ahead. So it's got gout, ototoxicity, low potassium, allergy, nephritis, dehydration, and alkalosis. Thiazide is glucose. So remember, it causes increased glucose, increased lipids, increased uric acid, and increased calcium. The only thing it decreases is sodium depletion and other electrolytes. So the other electrolytes are potassium. So it's causing hypokalemia. Mannitol side effects again, dehydration, hyponatremia, heart failure, and pulmonary edema. Calcium channel blockers, like I said, dihydropyridines and non-dihydropyridines. Please remember they block the L-type calcium channels. They can ask you in MCQ. These clinical pearls here are your MCQs, okay? So diltiazem acts by blocking L-type calcium channel. They've asked this before. Patients with bradycardia and hypertension after accidental ingestion of calcium channel blocker require immediate treatment. This is a one-line thing, but they will make a scenario of it. Okay, so they will give you a patient with calcium channel overdose. There'll be a lot of information, a really long MCQ, and what they're asking is this, basically. Or they can say the patient has taken an overdose of something, presented with bradycardia and hypertension, and now they're asking what they have taken. In the option, they might put in calcium channel blocker. Non-hydropyridine should be avoided in patients with heart failure or conduction abnormalities. This is also important. They will put this in an MCQ. ACE ARBs, we did this yesterday. Remember, all your prils are ACE inhibitors. All your sartans are ARBs. And direct renin inhibitor is aliskiren, and they will put this in an MCQ. This is another MCQ here. Side effects of ACE inhibitors, if you can remember, it's captopro. So C for cough, A for angioedema, P for pemphigus vulgaris. They have asked this MCQ. Which dermatological problem can ACE inhibitors cause? They put this there. T for teratogenicity, O for hypotension, P for potassium, R for renal failure, I for increased creatinine, and L for low GFR. Then you've got respiratory pharmacology, so antihistamines. First and second generation. Remember, second generation do not cause blood-brain barrier. Okay? Remember the names because they will put these names in your MCQs. They will not give you the class. Okay? And you will have to remember which one is it. These are your MCQs here. If you look at the clinical pulse, for truck drivers or those operating heavy machinery, non-sedating antihistamine should be given. And first generation antihistamine can be useful in allergic reactions or urticaria at night. Have a look at this one. You've got management of asthma in adults. So sympathetic stimulation, parasympathetic inhibition, and anti-inflammatory action. The thing that they will ask you in the MCQs and why I've mentioned this is they will put this here and ask you which one is short acting or long acting. Okay, they will put all of these in the MCQ so that just to confuse you, remember short acting for acute attacks and long acting for chronic management. Okay, side effects, important. So vasodilation, hypotension, tremors, they ask. Hypokalemia is also asked. Hyperglycemia as well. Treatment-wise, they can give you the escalation treatment. So they might say you've given them oxygen, you've given them beta-2 agonist, you've given them steroids, you've given them magnesium sulfate. What's the next in line? So theophylline. And because theophylline has a really narrow therapeutic index, they will ask you a lot of questions about its side effects. So remember this one as well, A, B, C, D. Affection for viral infection. Bad heart can cause heart failure. C for cirrhosis, and D for drugs because of its cytochrome P450 interaction, enzyme inhibitors. Okay. These are your cytochrome P450 drugs. Have a look at them before your exam again. On the day of your exam, just quickly read them so that you know you're not going to remember them just by one read. So have a look at these. What else is here? Respiratory pharmacology, asthma treatment. Again, we've already gone through this. All of this was in the slides, but this is just a rapid review, so I'm just going to cover this quickly. Ipratropium is an antimuscarinic agent that inhibits parasympathetic nervous system. Dose in asthma would be 500 micrograms or 0.5 milligrams every 4 to 6 hours. For salbutamol, the dose is 5 milligrams, and salbutamol is also called albuterol. Drugs that cause hypokalemia. Please remember these. So there's a mnemonic for this one. TCS 10-5. If you walk to a TCS office up to 5 to 10 kilometers, you will develop hypokalemia. So this is thiazide diuretic, corticosteroids, salbutamol. 5 is for furosemide, and then T10 is for theophylline. Okay? These are all the drugs that cause hypokalemia. First line treatment of asthma, we've done this. Anaphylaxis. Okay, so they ask you this question. Anaphylaxis versus anaphylactoid reaction. This will be there in your MCQs. Anaphylactoid reaction occurs on first time exposure and it is not immune mediated. Okay? This can come as a physiology question or a pharmacology question. It can confuse you, but they will ask you this in some capacity as physiology or pharmacology, both. While anaphylaxis occurs on further exposure and is immune mediated. Okay, key points here. All of these are UMCQs, all of them. First line treatment is IM adrenaline in anaphylaxis. Please remember the strengths. They will put this in an MCQ as well. So 1 in 1,000 is your IM strength of adrenaline. 1 in 10,000 is your IV strength for cardiac arrests. Okay. How many doses can you give? You can give up to 2 doses 5 minutes apart. That's another MCQ. Refractory anaphylaxis is when after 2 doses of IM adrenaline, the patient is still showing signs of anaphylaxis. Okay. Remember, steroids and antihistamines are not first-line treatments. And anybody on beta blockers with anaphylaxis, you have to give them glucagon. Types of angioedema. They can ask you this as physiology or pharmacology overlap. Remember this, that the allergic reactions are commonly seen with NSAIDs, which is mast cell mediated, and the bradykinin mediated can either be hereditary or ACE inhibitor. Okay, so if the allergic reaction or angioedema is happening because of ACE, it will be bradykinin mediated. If it is NSAIDs, it's going to be mast cell or histamine mediated. Okay, and any angioedema or allergic reaction that is histamine mediated will respond to adrenaline, and bradykinin mediated might not respond that well to anaphylaxis treatment. All right. This is again MCQs, and these are physiology overlap, but you might think, okay, they're asking about a drug, so it could be pharmacology, but it's an overlap of both. Now, blood pharmacology related, remember a few things here, which are low molecular weight heparin and their reversal agents. All of their reversal agents are important. So, unfractionated heparin. What's the reversal agent for heparin? Let's hear it. Do we remember? Protamine sulfate. Brilliant. Reversal agent for factor 10A inhibitors, rivaroxaban, apixaban. Do we remember? It might be difficult to type that one, but you have to know this. All right. What about warfarin? Warfarin we already did. I think you already are aware of this one. So heparin, remember this. The reversal agents are important. The rest you can all read. I'm just going through this file so that I can point out all the MCQ that you will have from this file and what to focus on. With warfarin, again, you have to remember these interactions, these ones, and the reversal agent. Please remember with warfarin, yes, vitamin K is the reversal agent, but if dried prothrombin complex is present, that's the answer. If it's not present, then fresh frozen plasma is the answer. Okay. Platelet aggregation, please remember aspirin is irreversible. They will put this in an MCQ. Aspirin, irreversible. and your clopidogrel is reversible. The GP2B3A abscessamab, they ask you this as well. The mechanism of action is what they ask you. With NSAIDs, they will ask you about gout. So colchicine, you will have a lot of MCQs about colchicine. Please remember about this one. Inhibiting beta tubulin from polymerization into microtubules. Exact words of an MCQ, please. So they will ask you, they will give you a scenario of somebody having gout, and they will ask you that there's a drug that you prescribe, which is colchicine. What is the mechanism of action? And they will put this in there. So they might put in COX inhibitor, they might put in decreased inflammatory system, they might put in the mechanism of action of allopurinol or probenecid. And what they're asking is this one. So inhibiting beta tubulin polymerization. Okay. Next is difference between gout and pseudogout. This might be a crossover with pathology. So positive and negative bifringent crystal, you have to remember gout is negative, pseudogout is positive. And what are the crystals? Calcium pyrophosphate crystals are with pseudogout, and urate crystals are with gout. Then you have adenosine contraindications. Please remember here, focus on asthma. They will put this in the MCQ. So do not give adenosine to asthma or COPD patients. They also ask you about mechanism of action of nitric oxide, which is cyclic GMP pathway. They give you the MCQ for metoclopramide, asking about this common side effect, which will be extrapyramidal effect. And they can ask you about the antidote of metoclopramide overdose, that is procyclidine. Okay. Tachyarrhythmia, benzodiazepine, we've already done. I told you about the benzodiazepine overdose as well. Please remember, what's the um, antidote for benzodiazepines? Do we remember? Lumazenol, brilliant. So that is also asked. Anaphylaxis and angioedema, here again, this is, again, go through this file and remember, this is more physiology of that, but they will use drugs to ask you this question. They're not going to ask you a simple physiology question like this. So this is a case scenario that they've asked. A patient presents with swollen lips and tongue unresponsive to IM adrenaline with a history of ischemic heart disease and hypertension. The medication most likely implicated. That's what they're going to ask. Okay. And in the options, they're going to put in some one ACE inhibitor and then some losartan, some diuretics, and ask you this. All right. And they can also ask you that you have given them ACE inhibitor, or that was the drug that was causing, what kind of angioedema will it cause? Is it bradykinin, antihistamine? Is it anaphylaxis? So they can ask you this as well. So it's bradykinin mediated. Drug interaction. So these are a few that can be asked about drug interaction. So 24-year-old woman with epilepsy presents with positive pregnancy test despite using contraceptives. She recently changed her medication. So what anti-epileptic is likely to affect her OCP? So the one that reacts with your OCPs is carbamazepine. Okay. With warfarin, they can ask this about your anticoagulation. Remember, it can mess up with the liver enzyme. So rifampicin would be implicated in that. Oh, this one is important. They will ask you this for sure. So 28-year-old asthmatic on salbutamol and theophylline presents with headache, dizziness, and tachycardia. After starting them on antibiotics, the suspected antibiotic that is causing all of these symptoms is ciprofloxacin. Why? Because it is inhibiting your cytochrome P450 enzymes, and the levels of theophylline are increased because of it. Okay? These are all your reversal agents here. And then you've got last minute pearls that you can just go over. nothing else that I would recommend going over. Okay. That is all here in the file. This will be shared in the classroom for all your regular course people. Do you want to do more MCQs? I can share them. If you don't want to do more MCQs, I'm happy to end the session because that is all that was planned, really.